Welcome to all. This is the first module of the Chalaram Diabetes Institute's course on diabetic foot management. And in this module, I will introduce diabetes and its complications, and I will try to provide you with an overview of the same. These are the learning objectives of this course. First, to know the diagnosis and classification of diabetes, to gain an overview of pharmacotherapy of diabetes, to understand the pathophysiology of diabetes-related vascular complications. Now, these are the learning objectives of this particular module of the CME Certificate Course in Diabetic Foot Management, or the CCC-DFM. The first task on our agenda is to understand diabetes and its classification. I'd like to introduce by saying that diabetes mellitus is a group of metabolic disorders characterized by chronic hyperglycemia. Diabetes may be because of inadequate insulin production or inadequate action of insulin. Sometimes other factors like glucagon, etc. also come into play. Diabetes is a multifactorial disease, and it's important to understand that when diabetes is uncontrolled, not just about the blood glucose, but when the blood pressure and the blood cholesterol are uncontrolled, this can increase the risk of damage to the blood vessels. These blood vessels may be small, also called microvascular damage, or they may be large blood vessels, and when they are damaged, it's called macrovascular damage. So diabetes can lead to microvascular as well as macrovascular complications, and therefore overall these complications can affect the heart, the kidneys, the eyes, the feet, and also especially the nerves and blood vessels of the feet. This slide shows you the classification of diabetes, and traditionally diabetes has been classified into type 1 diabetes, which could be autoimmune or non-autoimmune, type 2 diabetes, gestational diabetes, and other specific types of diabetes. Now, type 1 diabetes is a condition where the body does not produce insulin, and therefore insulin is the only treatment for type 1 diabetes. In type 2 diabetes is a multifactorial disease. It's not just insulin deficiency, but it's insulin resistance, glucagon excess hepatic glucose output, and it's also related to obesity as lifestyle factors as well. Type 1 diabetes may be because of the body fighting against its own pancreas, which is called autoimmune. It could be non-autoimmune. Type 1 diabetes affects the youth, but now we know that type 1 diabetes can occur at any age. Type 2 diabetes is multifactorial. It's due to genetics as well as environment, and environment, lifestyle factors play a big role in type 2 diabetes. The third type of diabetes is gestational diabetes. That means a lady who does not have diabetes has now become pregnant, and because of the dipedogenic effect of the hormones of pregnancy from a pre-diabetic or a non-diabetic state, this lady has now developed diabetes, and that's called gestational diabetes. Usually it gets better and gets resolved after the delivery of the baby, but during gestational diabetes, diabetes needs to be managed. There are various other specific types of diabetes. For example, there is pancreatic diabetes, where the pancreas is removed by surgery, and then the patient becomes diabetic. For example, somebody with a pancreatitis or pancreatic cancer has required surgery, pancreas is removed, and the patient now has become diabetic because the pancreas has been removed. The other type of second specific type of diabetes that we see commonly is steroid-induced diabetes. The use of, say, steroids like prednisolone can actually cause diabetes because steroids block insulin production as well as insulin action. So diabetes is of four types: type 1 diabetes, type 2 diabetes, gestational diabetes, and other specific type of diabetes. Now, many of you may be aware of a recent study from Europe which has said that diabetes is of several types, not just four types, and that is based on the clinical phenotype. Now, this is true for certain Scandinavian cohorts, but whether this is applicable to the rest of the world, we need more data for. Therefore, as of now, we are following the American Diabetes Association's guidelines on classification of diabetes. I'd just like to spend some time, because this slide shows all the other specific types of diabetes. I've already talked about pancreatectomy and diabetes. I've already talked about steroids and diabetes, but I want to spend some time on the other specific types of diabetes. For example, you may have genetic defects of the beta cell, and that is often causing diabetes, and those are called maturity onset diabetes of young, etc. There are some syndromes of insulin resistance that can happen. There are some endocrine diseases, for example, acromegaly, where there is excess growth hormone production, which can lead to diabetes. There are some infections like congenital rubella, which can lead to diabetes, and of course, certain common genetic syndromes that we see like Down syndrome, Turner syndrome. These diseases are also associated with the onset of diabetes. Now, this slide is very, very important, and I'd like you to focus on this slide because this slide talks about the diagnostic criteria for diabetes. So the common and easy way to diagnose diabetes in today's world is to do an HbA1c. As you know, the HbA1c is a single blood test that does not require fasting. Patient can give it at any time of the day, and that single blood test will give us the average blood sugar for the last 3 months. The HbA1c is described in terms of percentage, and if the HbA1c is more than 6.5%, then we say that the person has diabetes. How do we say that the HbA1c gives you an average of 3 months? Simply because the HbA1c describes a percentage of hemoglobin that is bound to glucose. If more than 6% of the hemoglobin is glycated or glycosylated, there are minor differences between glycated and glycosylated. I won't go into that now. But if more than 6.5% of the hemoglobin has glucose added to it, then we say it is diabetes, and we say that the hyperglycemia has lasted for more than 2 to 3 months. And why do we say 2 to 3 months? Because, ladies and gentlemen, as you know, hemoglobin stays inside a blood cell called the red blood cell, and the life of the red blood cell is about 90 to 120 days. So therefore, the hemoglobin A1c gives us an average of the last 3 months blood sugar, and if the value is more than 6.5%, we say that the person has diabetes. Now, before we started using hemoglobin A1c for diagnosing diabetes, we used to measure fasting glucose, we used to measure post-meal, or rather post-OGTT glucose. After giving 75 grams glucose, 2 hours later we used to do a blood sugar level, and then we used to diagnose diabetes. So if the fasting was more than 126 or equal to 126, we call it diabetes, and if the post-OGTT or post-meal glucose level has touched 200 or more, then we call it diabetes. Now, the final way to diagnose diabetes is a casual or random blood glucose level, which means random means without relation to the time of the day or without relation to the food intake. If you take a blood glucose test and if you find the value of 200 or more with certain osmotic symptoms. What are the osmotic symptoms in diabetes? Excess thirst, excess appetite, excess urination. If you find all those in weight loss, if you find those symptoms with a random sugar more than 200 or equal to 200, we call it diabetes. So diabetes can be diagnosed by any of these ways. Glycated hemoglobin, HbA1c, N1-deoxyfructosyl-valine beta hemoglobin. This is commonly referred to as HbA1c. Glycemic management is primarily assessed by HbA1c, which reflects the glycemic changes over a period of 90 to 120 days. HbA1c should be measured 2 to 4 times per year in diabetes. This slide shows the conditions that may preclude accurate HbA1c measurement. Number 1 is anemia or hemoglobinopathies. Second is chronic renal failure or hepatic failure. Third is hypertriglyceridemia. The fourth is the use of medications such as erythropoietin, antiretroviral drugs, chronic opiate use, and alcoholism. It's important to clinically check for these conditions and do appropriate testing to detect these conditions that may preclude accurate HbA1c measurement.